So that is the work on spiritual crises that I had been involved with, leading to the DSM category. And what I found was that over time, whenever I would be presenting on the topic of spiritual crises, it was necessary to really engage a broader range of issues, such as how does one show respect for a client's spirituality? How does one conduct a spiritual assessment to find out more about what that particular client believes and values? And do they have any background in the areas that they're currently talking about? So that required a broader approach. And I started a website called spiritualcompetencies.com. And I started to reflect more broadly about how does a therapist show competency around the whole topic of spiritualities, not just when a client is having a crisis, but when they might come in with an experience like loss of faith. They are demoralized because they no longer hold the same religious or spiritual values that were so important to them. So a group of us over time collaborated on the topic of finding a way to more broadly define the kind of competencies that every mental health professional should have to deal with clients' religious and spiritual beliefs and practices. So what I would like to do now is share with you a slideshow that deals with the topic of spiritual competencies. So let me go ahead and get that up as a PowerPoint. So this is going to be a little bit about the development of spiritual and religious competencies. And we focused on psychologists. It was necessary to have a disciplinary focus in order to conduct the kind of research and to get the results of our research published. So it does focus on psychologists, but I think it is generally applicable to all people who are mental health professionals and therapists and spiritual guidance, spiritual guides as well. So, first of all, in many settings, I have to start by even answering the question of why bother to address religion and spirituality. And here the research over the last 15 years has demonstrated how important spirituality is. For example, religious coping has been shown to contribute to mental health, including the ability to deal with stress, to cope with anxiety, depression, suicide, substance abuse, as well as increasing hope and well-being and optimism. And at one point, I used to have a 90-minute PowerPoint presentation summarizing all of the research in this area, demonstrating that spirituality is associated with illness prevention, and here I include things like depression, anxiety, PTSD, as well as substance abuse, as well as coping with these. If a person does become depressed or develop PTSD, their spirituality can help them cope with it. But just on the medical level as well, there's very compelling research showing that people recover from surgery more effectively if they have a spiritual component in their life. And it, across the board, improves treatment outcomes. So those are some of the kinds of reasons. And people who have looked at the impact of substance abuse, for example, have shown that individuals suffering from alcohol or drug abuse are found to have a low level of religious involvement, and yet spiritual re-engagement appears to be correlated with recovery. So that's one example where the research has demonstrated the power of spirituality to both forestall or prevent substance abuse, but also to help people recover. And when one looks at the actual impact size, you can make the argument that, quote, infrequent religious attendance or poverty of personal faith, namely spirituality, should be regarded as a risk factor for morbidity and mortality that is nearly equivalent to tobacco or alcohol abuse. So that's pretty powerful. If a person lacks spirituality in their life, that's equivalent to engaging in alcohol abuse, at least at the level of impact on their well-being. Now, I realize this presentation is international, and so from country to country this varies, but here in the United States, if you look on the left, you can see that in the United States, people have a very high level of belief in God. It's over 95% in all ages. When you look at membership, you can see that membership is still pretty high, although with younger people, it ain't as high. And the same with its importance and attendance. Younger people participate less, but if you're looking at middle-aged and above people, there's a lot of involvement with religion. So here in the United States, competency may be more important than perhaps in a country like France, where way fewer people are involved with religious practice. However, spirituality is replacing religion in many people's lives. Many people nowadays identify as spiritual, but not religious. But therapists often report, in fact, 60% of psychologists report that clients often express their experiences in religious language, and 1 in 6 actually present issues which directly involve religion or spirituality. And that 72% of psychologists say that at some time in their careers, they have addressed religious or spiritual issues in treatment. However, when we look at the field of mental health, we have to start with the negative views that the founders of the field of psychology have bestowed upon us. So Sigmund Freud wrote a whole book about religion that he called The Future of an Illusion, where he defined religion as a system of wishful illusions together with a disavowal of reality, such as we find nowhere else, but in a state of blissful, hallucinatory confusion. So he had a very negative view. He actually, in his letters, described religion as the enemy of psychiatry. And this is a cartoon where the good Dr. Sigmund Freud is looking at the meditating Buddha and labeling him as overprotective father, displays catatonic, obsessive compulsive behavior patterns, possibly catatonic. So that was actually what meditation was described as in mental health and psychology journals from the 1970s through 1970s. It was described as a state of artificially induced catatonia. So we have come a long way from that now, where we recognize the value of mindfulness practices for clients. Another pioneer in the mental health field was Albert Ellis, and he's often given credit for being the father of cognitive therapy, that is part of cognitive behavioral therapy. And this is what he said about spirituality. Spirit and soul is horseshit of the worst sort. Obviously, there are no fairies, no Santa Clauses, no spirits. What there is human goals and purposes. But a lot of transpersonalists are utter screwballs. And B.F. Skinner wrote a novel. He never discussed religion in any of his publications. He had over 600 articles and a dozen books without ever once addressing religion or spirituality. But in his novel, the protagonist called religion an explanatory fiction of a miracle working mind, and prayer and ritual that he described as superstitious behavior perpetuated by an intermittent reinforcement schedule. In other words, if you pray for things, then every once in a while, by random chance alone, what you pray for will come to be. And people will misinterpret that because it happens intermittently, and they will perpetuate their belief in prayer, even though there's absolutely no basis for that. So he also had a highly negative view of religion. And this cartoon captures that a little bit too, where this doctor is looking at this individual radiating well-being and saying, "You've been fooling around with alternative medicines, haven't you?" Alternative medicines like mindfulness, acupuncture, and so on, things that we now recognize as evidence-based practices. But it wasn't long ago that they were viewed as fringe and not validated methods. So also there's been a change where, in this case, the American Psychological Association recognized that spirituality and meaning need to be considered, that understanding that people are cultural and spiritual beings is a necessary condition for psychology of human existence. And the American Psychiatric Association also noted that the religious convictions of patients can be used effectively in therapy. Religion can be a usable support system for the patient, even when the psychiatrist believes the patient's religious system has no objective value. In other words, it's necessary to respect the client for his or her beliefs and convictions rather than coming at it from what the therapist believes. So one of the results of this negative attitude has been that, on the average, psychologists report discussing spiritual religious beliefs and practices with only 30% of their patients, despite the evidence that for most people, their religion and spirituality is an important part of their self-identity and their values, and actually is a strength in most of their lives. And I think another factor that has validated the importance of religion and spirituality is that in the United States, the Joint Commission on Accreditation of Healthcare Organizations, which is a licensing board that all hospitals in the United States have to be accredited by, and this organization mandates that the spiritual components of a person's life must be considered in healthcare. A spiritual assessment should at least ascertain a patient's religious belief, a preference, beliefs, and any spiritual practices. And the assessment must be documented in the patient's chart. So that is another push for mental health professionals to develop some competency in how to talk to their patients about their spiritual lives. And in the United States also, the National Center for Complementary and Integrative Medicine considers religion and spirituality to be a type of mind-body medicine. And this is part of the National Institute of Mental Health, and they now have a budget of over $100 million to support research on mindfulness and other topics within religion and spirituality. So again, this category that I mentioned earlier in the DSM was another opening for mental health professionals to describe and discuss their clients' religious and spiritual beliefs and practices and experiences with them. So, as I mentioned, it became clear to me and some of my colleagues that we needed a broader set of competencies because we as a field cannot move forward to develop ways to train psychologists so they are competent to address this realm unless we have a validated set of competencies. And in the literature, competencies are defined in terms of core attitudes, knowledge, and skills, where attitudes and beliefs refer to the implicit and explicit perspectives and biases people hold about spirituality and religion. Knowledge refers to information, facts, concepts, and awareness of research literature around spirituality and religion. And skills refer to psychologists' ability to actively and effectively utilize their knowledge of spirituality and religion in their clinical work with clients. So that's the distinction between attitudes, knowledge, and skills. So in phase one of our research, we developed an initial set of competencies, first by convening an expert focus group to have several discussions about this. These occurred between 2008 and 2011, and we further discussed these at an American Psychological Association where we did a presentation in 2011. And then we developed, we took and ultimately suggestions from 105 professionals who were considered, I guess I should say, they consider themselves proficient, were very proficient in the realm of religion and spirituality. So based on these focus groups and presentations, we developed a list of 29 competencies. That was phase one and two. In phase three, we developed an online survey, and we contacted 189 mental health practitioners who were self-acknowledged as proficient in the area of religion and spirituality, and had them look at these 29 proficiencies. And based on their rating of these, we were able to narrow it down to a list of 16. And then in phase four, we were able to present those 16 to a broader group of students and newly licensed and fully licensed professionals who were not proficient in religion and spirituality. We were able to get them to participate in the survey by having a raffle prize of an iPad that people were given tickets for the raffle if they participated in the survey. So as I mentioned, phase one and two resulted in 29. Phase three resulted in 16 core competencies. So as part of the survey, we asked whether the competency was described clearly. We asked for any changing in wording they might suggest. And then we asked for their ratings of their own self-perceived proficiency. And we also asked them to rate how important they saw that proficiency. So these were all considered. and we removed items with low rated importance. And we reworded unclear items and looked at suggestions. And based on that, we were able to come up with a list of these 16 competencies. And let me mention that we were able to come up with a list, and we were able to get that published. And based on publishing, we were able to share it with a much wider professional group. And I will, as part of this presentation, put up a link to the articles and also to the list of competencies. And I also just want to mention that Cassie Veaton, who was the lead author on the research, and Shelley Scammell also produced a book by New Harbinger that goes into much more detail about the nature of these competencies, the definition, and include resources and exercises for people who want to become more proficient in these 16 competencies. So I'll end the presentation here. I hope this will generate some discussion and some comments that I will be able to respond to, and that we will be able to have some kind of online discussion of this. Thank you for your attention here.